Thank you very much. Broadly speaking, what are the factors that determine colorectal cancer outcome? I mean, I think it would be fair to say that tumour stage at resection is probably the biggest single factor that people consider, but that may be only half the story. And actually how the patient responds to their disease, so the host responding to their tumour, may be equally, if not more important. When I talk about the host response, I primarily mean the host inflammatory response. And that has two main components. So the systemic response, which we know from a large number of studies over a number of years, is a bad prognostic sign. And the local response, and it's really this local response at a cellular level that is the focus of this study. And nowhere is this kind of more apparent, this interaction between tumour and host more apparent than at the invasive margin. And that is the part of the tumour that we're going to study. Of course, we're not the first to investigate the link between inflammation and cancer outcome. And in fact, this Finnish study by Klintrop and Mäkinen, published in 2005, suggested that simply grading the inflammatory response on H&E sections as just a global weak or strong was in fact more prognostic than Duke stage itself. But we wanted to build on that and examine it in more detail. So we had three main aims. First, which inflammatory cells are actually present within the invasive margin and in what numbers? Second, which specific cell types are most advantageous to survival? And finally, what clinical and pathological factors do they relate to? Why do some people get a strong response and some don't? To do this, we extracted 130 patients, all having undergone potentially curative resection of colorectal cancer at Glasgow Royal between these dates, and they therefore had mature follow-up of between 5 and 15 years. Over the years, we've collected a number of clinical variables. I think we're up to about 40, things like demographics, smoking status, comorbidities, laboratory values, and we also had previously collected the systemic inflammatory response, GPS, Glasgow Prognostic Score, a measure of CRP and albumin. And we had previously used this Klintrop-Mäkinen grade for the local inflammatory response. We also had fairly standard pathological variables, TNM stage, venous invasion, etc. So to do the study, we retrieved the original H&E sections from the pathology archives, and with the help of a pathologist identified the margin of deepest invasion, shown here by the black line. Along the length of that margin, we then chose 5 distinct areas to examine at high magnification. This is one of these areas. We superimposed grid lines over and chose 10 random boxes in which to count and classify the inflammatory cells. This meant that for each case, 50 boxes were counted, an area of approximately 0.1 millimeter square. And cells were classified as lymphocytes, macrophages, neutrophils, plasma cells, eosinophils, and other cells. And you can see our inter-observer correlation fairly good across the board, slightly less for macrophages. To the results, this is the clinical pathological characteristics of the cohort. A fairly similar number of males and females spread across the age ranges. Approximately 2/3 for colon cancer, 1/3 for rectal cancer, and mainly for stage 2 and stage 3 disease. So which cells are actually present at the invasive margin? Well, we can see that in the majority it's lymphocytes, macrophages, and neutrophils, and to a lesser extent plasma cells and a scattering of the eosinophils. We then went on to ask which cell types are actually increased in this Klintrop-Mäkinen reaction as described previously. Well, we can see there's a big increase in the number of lymphocytes. Similarly, a big increase in the number of plasma cells. Neutrophils do increase, but not to quite such a degree. Macrophages, in fact, there's no increase, and eosinophils do increase, but in very small numbers. So which cell types are important to survival? Well, there was no survival benefit at all for macrophages, neutrophils, or eosinophils, but there was a survival benefit for a high number of lymphocytes. Similarly, there was a strong survival benefit for a high number of plasma cells. So what does that relate to? So we know that the patients with a good lymphocytic response are doing well. And when we looked at that, there was no relationship with any of the clinical variables that we had. So it didn't matter if you were male, female, your age, whether you had anemia, smoking. And interestingly, your systemic response did not appear to be related. So high levels of circulating lymphocytes actually was unrelated to lymphocytes at a tissue level. In terms of the relationship with pathological variables, there was a number of interesting associations, and in particular, venous invasion. Both lymphocytes and plasma cells were associated with a greatly reduced incidence of venous invasion. And that was something to the order of 50% venous invasion if you had low levels of lymphocytes, or to around 10% if you had high levels. When we put that into a multivariate survival model, we can see 4 things were significant: systemic inflammatory response, TNM stage, evidence of venous invasion, and interestingly, the Clintrop-Mackinnon response. So I guess what this is telling us is that although lymphocytes are perhaps the most important individual cell type, in terms of using this clinically, Clintrop-Mackinnon still seems to provide the prognostic information. What can we conclude from this? Well, the invasive margin certainly does represent an interface between tumour and host. Lymphocytes and plasma cells seem to be the cell types most associated with survival. And they're associated with a number of favourable pathological characteristics, in particular, less venous invasion. So we would overall conclude that the adaptive immune response plays a key role in the prevention of tumour progression in colorectal cancer. Thank you.